Hello friends, myself Dr. Noreen Patel from Oral and Maxillofacial Pathology and Oral Microbiology from Nursing by Patel Dental College SPU. I'm here to present a case. A 15-year-old male patient came with a chief complaint of swelling in upper right front tooth region since last 2 months. An associate complaint was food lodgement in lower left tooth region since last 10 to 15 days. Patient was relatively asymptomatic before 2 months. Then he noticed swelling on upper right front tooth region. Swelling was gradually increased over last 1 month. No complaint of pain in same region and no post discharge. So he came to Narsibai Patel Dental College with a chief complaint of swelling in upper right front tooth region. There was no relative history of medical, dental and family. Patient is vegetarian, no harmful oral habits. He brushes his teeth once in a day with a toothpaste and toothbrush in horizontal manner. Patients on extraoral examination is essentially normal. Patient's gait was normal, average built, average nourished. There was no sinus paler and icterus. The extraoral examination is essentially normal. On intraoral examination, hard tissue examination, the number of teeth present are from 1 to 7 and the C over-retained C was also present. There was class 1 caries. Mild calculus was also present and 3-6 tooth vertical fracture was also present. On gingiva, the shape, surface texture, contour and color was normal. There was no bleeding on probing. There was no pocket present. On extra oral examination during inspection, a diffuse swelling of approximate 2 into 3 centimeter extending from on right side 2 centimeter away lateral to the nose to 3 centimeter anterior to tragus and on inferior superiorly 1 centimeter below inferior border of orbit and 3 centimeter above lower border of mandible. On palpation, all inspectory findings were confirmed and a solitary bony swelling of size 2 into 3 centimeter, non-fluctuating, non-tender, temperature was not raised, overlying skin was also normal. On inspection, a solitary bony swelling from 1-3 to 1-6 region is present. Vestibular obliteration was also present. Carious tooth with respect to 3, gastric carious tooth with respect to 3-6 was present. All palpation, bony consistency, painless overland mucosa was normal and tenderness on percussion was present. On oral panthogram, ill-defined radiography with respect to 1-3 to 1-5 region is present. You can see that. And well-defined radiolucency with respect to 3-6 is also present. So basis on above, the provisional diagnosis was given as unilocular ameloblastoma with respect to 1-6 and radicular cyst with respect to 3-6. So differential diagnosis. So the similarity between OKC with the OKC is that they both have remnant arises from the remnant of dental lamina. The mandible is more than maxilla. It is a asymptomatic bony hard swelling, and the difference is that multiple lesions may develop in the jaw as manifestation of the nevoid basal cell carcinoma syndrome. Unilocular radiolucency with well-defined rim is also present. With dentigenesis, the similarity is that they both are asymptomatically detected incidentally during radiographic examination. Mandible, the chances of mandible is higher than maximal. Large lesion produce swelling of the jaw with facial asymmetry. Derived, the difference is that they both are that this is derived from reduced enamel epithelium developed around crown radiolucency. With respect to 1/6 for periapical granuloma, the involved tooth is non-vital. Tenderness on percussion is present. Carious tooth, pulpal inflammation or infection beyond the root apex, asymptomatic. The difference is that the localized mass of granulation tissue around the root apex developed in response to low-grade infection or the inflammation, size is less than 2 centimeter in diameter. In periapical, the similarity is that it is a localized suppurative infection in the periapical region of the non-vital tooth, and the difference is that severe pain, erythematous change in overlying mucosa, pus discharge, body temperature elevated, and lymphadenitis. So, summary: a male patient of 15-year-old visited Department of Oral and Maxillofacial Surgery with a chief complaint of swelling in upper right teeth region since last 2 months. Swelling increased in size gradually over last 1 month. No complaint of pain, pus discharge on same region. On examination, a diffuse swelling on right side of approximate 2 into 3 centimeter, extending from 2 centimeter away from lateral side of the nose to 3 centimeter anterior to tragus, 1 centimeter below inferior border of orbit, and 3 centimeter above lower border of mandible. Bony swelling present from 1/3 to 1/6 region. Vestibular obliteration is present from 1/3 to 1/6 region. Grossly carious teeth with respect to 3/6. Sol palpation, a solitary swelling of bony consistency. Swelling is non-fluctuating and non-tender. Overlying mucosa is normal. Tenderness on percussion present with respect to 3/6. So on the basis of history and clinical examination, provisional diagnosis was given as unicystic ameloblastoma with respect to 1/6 and radicular cyst with respect to 3/6. CT scan shows the bone perforation. Now, histopathological report with respect to 1/6. H&E stain section shows cystic lining and connective tissue capsule. The cystic epithelium lined by non-keratinized stratified squamous epithelium with varied thickness, duct-like structure surrounding the cuboidal cell, mucous goblet cell, and few clear cells were also identified, and the layer of epithelium, so eosinophilic cuboidal cells called the Hobnail cells. The underlying connective tissue shows few clonic inflammatory cells infiltration suggestive of glandular odontogenic cyst. Now this forex section shows the cystic lining by non-keratinized squamous epithelium with varying thickness, and connective tissue shows inflammatory cells. Now, in this figure shows the non-keratinized squamous epithelium of varied thickness and connective tissue stroma with inflammatory cells. This shows the duct-like structure surrounded by cuboidal cells, and the mucous goblet cells can be seen. Shows the Hopnell cells and the duct-like structure and a clear cell. So there is a major criteria and minor criteria given by Kaplan. The major criteria includes the variation in thickness of the lining with or without epithelium, sphere or hole, no palacites, squamous epithelial lining with flat interface, cuboidal eosinophilic cell or the Hobnail cells, mucous goblet cells with interepithelial mucus pooling with or without crypt-like by mucus producing cells, interepithelial glandular microcyst or duct-like structure. The minor criteria includes the papillary projection, ciliated cell, multicystic or multi-illuminated architecture, clear or vacuolated cell in basal and spinosal layer. Now, with respect to 3/6, the H&E section showed cystic lining and the lumen epithelial lining is stratified squamous epithelium, thickening ranging from 5 to 20 layer cell. Connective tissue composed of parallel bundle of collagen fiber, fibroblast, lymphoblast, plasma cell. There was Rusten body. It is a hyaline body found in epithelium. It is tiny layer, linear or arc-shaped body, amorphous structure. The proliferating cystic epithelium may also show peculiar fashion by enclosing and encircling a mass of connective tissue capsule from all side pattern known as the arcading pattern. This is a suggestive of radicular cyst. So in the figure, we can see the arcading pattern and the stratified squamous epithelium. So the final diagnosis was made as glandular odontogenic cyst with respect to 3-6 and radicular cyst with respect to 3-6. Now we will see the discussion part. Cyst, its definition, it is defined as the pathological cavity may or may not lined by epithelium and containing fluid, semi-solid or the gaseous material which is not formed due to accumulation of pus. Pathogenesis of cyst formation, it generally takes place in 3 stages: initiation, cyst formation, and enlargement of expansion of cyst cavity. Initiation. In developmental cyst due to unknown etiology or in inflammatory cyst due to bacterial infection, initiation of cyst formation occur. Proliferation. The stimulation leads to the excessive and exuberant proliferation of the cell, which leads to the formation of the large masses or the islands of immature proliferating epithelial cell. Once the large mass is produced, its peripheral cell gets adequate nutrition supply. As a result, central and the innermost group of undergo necrosis while peripheral cells survive. This give rise to the formation of the cavity that contain hollow space or lumen inside the mass of proliferating cell and peripheral lining of epithelial cell around it. Enlargement. Higher osmotic tension of cystic fluid causes progressive increase in the amount of fluid inside its lumen, and it causes increased internal hydrostatic tension within the cyst. The epithelial cell of the cystic lining release some bone resorption factors like the prostaglandin and the collagenase, which destroys the bone and facilitates the expansion of the cyst. This is the classification of the cyst by shear. Glandular odontogenic cyst. It is also known as the silo-odontogenic cyst or the mucoepidermoid odontogenic cyst. It is a large intraosseous odontogenic cyst which often exhibit a aggressive courses. The cyst consists of stratified squamous epithelium and the area of numerous mucus secreting cell. The mucus secreting cell often produce pools of mucin within the cyst. Its origin, it arises from the remnant of dental lamina and are capable of granular differentiation. Epidemiology, it is 1% of all odontogenic cysts. You can see the graph. It is usually seen among the adult. There is no gender predilection. Peak occurrence is the 5 to 7 decades. The most common affected site is maxilla, and it's mainly the anterior mandible. Clinical feature, it is slowly progressive growth, swelling, and paresthesia. On radiographic feature, a unilocular or multilocular radiolucency arises with the demarcated and the sclerotic border. You can see in the slide. Histopathologically, cyst is lined by non-keratinized squamous non-keratinized stratified epithelium of varying thickness, cuboidal or columnar ciliated surface lining with the goblet cell. The epithelium has a glandular or pseudoglandular structure with the goblet mucus producing cell as well as the interepithelial crypt or the microcyst containing mucus. Microcyst may form duct-like structure. You can see in figure. Treatment. Small unilocular lesion can be treated by enucleated. Large unilocular isolated lesion includes marginal resecting or partial jaw resection in multilocular lesion. Tendency of recurrence is more. Follow-up for at least 3 years should be continued. For radicular cyst, periapical cyst, most common odontogenic cystic lesion of the inflammatory origin. So it develops due to proliferation and cystic degeneration of epithelial cell rest of molars. Epidemiology, 50% or more among all types of jaw cyst seen in third, fourth, and fifth decade. Male is more commonly affected than female. The most occurring site is maxilla, then mandible, and maxilla anteriorly, then mandibular, premolar, and then molar. Clinical features, it is asymptomatic, generally associated with non-vital deep caries and restoration, pain on percussion, tenderness on percussion present, and a large lesion show hard bony swelling. The radiographic features will show unilocular round shape radiolucency in periapical region with the non-vital teeth, large carious cavity, or the fracture on the crown. Histopathologically, cystic cavity is lined by the non-keratinized stratified squamous epithelium of about 6 to 20 cell layer thickness, and the lining epithelium is backed by well-vascularized connective tissue stroma. The proliferating cystic epithelium may sometimes grow in a peculiar fashion known as the arcading pattern. Cyst contains the cholesterol cleft and the rostrum body. Round or the irregular shaped island of squamous epithelium was found in capsule known as the base cyst. Cholesterol cleft. So there are multiple small ribbon-shaped or the needle-shaped cleft-like spaces. They are found in the cystic lumen or in the connective tissue capsules. The degeneration of red blood cells, degeneration and disintegration of lymphocyte, plasma cell, and macrophages. They circulate in the plasma lipid. Now, Ruston body, they mainly found in the epithelium, hyaline body, tiny linear and the arc-shaped body appear amorphous in structure, eosinophilic in reaction, brittle in nature, secondary product of odontogenic epithelium cell. The thrombus formation is small capillary, formed chiefly from red blood cells. Treatment, small cysts are treated by root canal treatment of the affected teeth and the apical curettage. Last cysts are treated by the extraction of involved teeth and careful curettage of the periapical tissue. The prognosis is good. These are my references. Thank you.